I'm trying to figure out how I should share the correct screen. Just bear with me. I've got this. Give me a couple of seconds.
And it has a home.
So, sorry, Dr. Singh, I couldn't hear you like before I saw that you were speaking, but my volume was not turned on.
Oh, yeah. I was just saying, just bear with me a second. I'm just trying to figure out, you know, with the 2-screen thing, like you should share the correct screen. That's what I'm trying to get to. I think.
Oh, okay, perfect. Right now we can see the presentation.
Okay, great. Okay. Trying to also see most of you. Okay, I can also now see most of you. Okay. So good afternoon, everyone. It's never easy to have the third slot for the day. And so my plan had been to show you a bunch of YouTube videos instead of boring you and putting you to sleep. So we'll see if I can upload, like if I can stream some of them. I'm not really good at this. So I'm Vasundhara. I'm a hospitalist. I've been a hospitalist several years now. I've been at West for about 4 years out of those. And you know, syncope is something we see a lot, right, in several contexts. And whether you're categorical, sort of hospital medicine bound, or outpatient, whether you're subspecialty bound, or you're going into neurology or ENT. Well, there's no one going into ENT. Regardless, several specialties will deal with this, and you will deal with this as a physician on a plane, and as a physician walking down the sidewalk. And I think syncope is in general a really helpful topic to know really well. And personally, my favorite guidelines are the European Society guidelines. The original ones had come out 2019. The most recent ones, 2009, the most recent ones are 2019. They're excellent, very readable. So if anyone really gets into this topic, that's my source essentially for the talk. We're going to go through 8 case-based sort of patients, and I want you guys to discuss it amongst yourselves. And then we're going to sort of do some pearls along the way, right? And the most helpful thing is to actually, let me see. Everyone can see each other, right? Good. Is just unmute yourselves, whoever feels like talking, and just tell me what you think syncope is. Let me not give it away. Yeah, tell me what syncope is. Because we love definitions in medicine. And then really the reason I think syncope specifically is an important definition is because it tells you what it's not. It's really important in the case of syncope to know what it's not. Omar, do you want to take a stab? You look like deep in your thoughts.
So I define it as loss of consciousness, like due to cerebral hypoperfusion, likely.
You already read that slide. God damn it. Yeah, I mean, so I think you got it. So it is a transient loss of consciousness, right? So the loss of consciousness is really important, but the more important thing is that it's very brief. And the beauty of this definition, and this was actually not the original definition, the beauty of this definition is that they included the etiology of the loss of consciousness, which is global cerebral hypoperfusion. So seizures are not syncope because the underlying etiology is not hypoperfusion. A heart attack may cause syncope if it causes global cerebral hypoperfusion. So they've included the etiology, and I want you to sort of remember that. And they've included some characteristics. So they said it's rapid onset, it's short duration, and there is spontaneous complete recovery. And the spontaneous complete recovery is also extremely important. So if your patient didn't come back to their neurological baseline, it's not syncope, right? Okay, wonderful. So this is sort of from 10 years ago, but I still really like it. And the reason is that it sort of helps you to think through the other things that are syncope mimics and ask questions in such a way that you're ruling some of these things out. So the first thing is, was there a loss of consciousness? And if there wasn't, then really it was a fall or it was altered consciousness, but it wasn't. Do I have a pointer? Let me see. Can you guys see this? Yeah. So it was a fall, altered consciousness. It wasn't syncope. If there was loss of consciousness and they did not come back to baseline, it's not syncope. It's coma or something else. Now, if there was a transient loss of consciousness, you're coming into the realm of syncope. Was it traumatic? If it was traumatic, it's not syncope. And then you go down your non-traumatic route. And even in that, you can see there are various causes of people transiently losing consciousness. Syncope is just one of them, right? And at this point, I was going to show you a video of boxers punching each other. Is there a way to stream that, Rafa? It might be the first, or Sani, it might be the first video. I don't know, my dad's really into boxing and he keeps sending these annoying videos.
Needed the body out of the break for Jamal Hill, who has an early moment with which to work.
Yeah, if I'm if I'm Jimmy Crew, you're getting.
Oh! You got it! Do it! Jamal Hill! Sweet dreams! Cars that matter in DC.
Perfect. So was that syncope? Yeah, so that's the point, right? That was not syncope, right? I just wanted to get your attention. Good. All right. So let's see. You guys, can you see the case one on your screens?
So yes, right now we're seeing it like inverted in the presenter mode, but we see your like next slide as well.
Okay, I see. Good. Then you get to read both.
Okay.
I'll fix it. But someone start reading the first case for me. Sonal, do you want to start?
26-year-old female with no significant past medical history, presenting with syncope and setting of heated argument with parents. No prodrome. Witnesses arm shaking for 2 to 3 minutes. Urinary incontinence. Upon waking, the patient is confused, disoriented for more than 1 hour, woke up not orthostatic, and exam with horizontal nystagmus and tongue bleeding, labs and EKG normal. Given the history of shaking and given this history of shaking and tongue bite, I'm inclined to think in terms of like seizure, and I would rule that out because patients might have loss of consciousness, not just because of syncope, but because of neurological causes like seizure as well.
Good. I mean, I think you did your fair share. Are you guys seeing the right screen now? It's a single screen?
Yes.
Okay, good. So then let's see. What would you do next? Would you do no further testing? So you're in the ED, you're working an ED block. So would you do no further testing, discharge home? You would call the hospitalist and say, here's an observation case, get an echocardiogram or a head CT or an MRI. You would call the cardiologist and say, hey, does this person need a stress test, or would you start fludrocortisone? So unlike Sonal's thought process where she was thinking about potentially potentially a seizure, I haven't even considered a seizure, or I may have, and I've put a head CT in there for perhaps a first-time seizure workup, right? I'm not getting an EEG. So how many, just raise your hands because we're not doing a poll. How many would do one? Omar would do it. Adrian would do it. Here's your cavalier docs. They're just like, you're fine. Heated argument is enough reason for you to pass out. You're young, you're not orthostatic. You're talking to me, you're just fine. You have some horizontal nystagmus, which I can't explain, but who cares? Okay, how many would get her an echocardiogram?
I would do a CT. No.
Who wants a CT?
Witnessed. Okay.
Everyone wants a CT.
Come on, Nikki.
Lots of hands. Some like cool little emoji hands. I love it. Who would get a stress test? No one wants a stress test. You guys are after my own heart. No one wants to fludrocord, right? That's such a useless option. Good, excellent, right? So exactly what Sonal said, this is likely a first-time seizure. And when you look back at the question stem, there's a lot that I planted in there. Sure, it happened, when she had a heated argument, but she had urinary incontinence. That to me is a big flag. She was confused and disoriented for an hour. That's not syncope. She had this tongue bleeding, and we can talk about this further. She had horizontal nystagmus. These are all really concerning signs that this is not syncope, right? Okay, excellent. You guys are geniuses. So there are multiple conditions that are misdiagnosed as syncope, and you will receive patients from the emergency room with the sort of working diagnosis being syncope, and your job is really to get to the bottom of it, right? So there are disorders with partial or complete loss of consciousness, but they are not due to global cerebral hypoperfusion. And then there are disorders with impairment of consciousness, but that's not a true loss of consciousness. So you really need to dig to get to the bottom of it. And any syncope case is not solved with imaging or echocardiograms or telemetry. It's really solved with a good history, right? So for epilepsy, that persistence of that postictal phase is very significant. So you really want to ask those questions that signify someone may have been postictal. Metabolic disorders like hypoglycemia, hypoxia, hyperventilation with hypercapnia, they often mimic syncope. But the most common sort of story you'll hear is that they were sort of near syncope, right? Or pre-syncopal. They'll be lightheaded, but they didn't quite syncopize. And you want to start thinking about some of these metabolic disorders. TIAs are really difficult to tease out because some TIAs, they come with this sort of vagal component early on. But the key for anything that's a TIA or stroke is a focal neurological deficit. If you don't have a focal neurological deficit, it's not a TIA. But remember that there is a vagal component to a lot of strokes. Drop attacks, you don't lose consciousness. There's really a loss of postural tone. We're in the, in the box now for disorders without impairment of consciousness. And then anyone who know what this cataplexy is? As I was prepping this lecture, I was like, well, I don't know what that is.
Lots of motor.
Nadeem knows. Okay, what is it?
Oh, it's they get like sudden onset loss of like motor strength, so, like they fall. It's right? I don't know. It's
Yeah, that's exactly, you hit it on the head. That's exactly it. So it is a sudden brief loss of voluntary muscle, and it's triggered usually by strong emotions, even laughter. I once had a patient who would like literally fall but not lose consciousness with just strong laughter, and it's associated, there's a huge association with narcolepsy. So really, I always think about this cartoon when I'm doing a syncope evaluation, and I can never tell the plants from the weeds. So pull up all of them, and the ones that grow again are the weeds, right? So once you've started recognizing some patterns of these conditions, you'll learn to recognize stories. All right, Darren, do you want to read case number 2?
Sure. So 26-year-old male with no medical history presenting with syncope in the setting of heated argument. Prodrome this time is that she was lightheaded, no palpitations, chest pain, dyspnea. Witnesses some arm twitching, looked pale. Upon awakening, nauseated, fatigued, felt better after 15 minutes. Further history, passed out like this before, but otherwise very active without issues. Workup not orthostatic, normal exam, lab is an EKG normal.
Darren, what sort of struck out to you about this case?
So I think that looking pale is something that stood out to me the most. And also previous history of passing out before without other active issues. So those are kind of the two things that looked at for me first time.
Beautiful. Yeah, that's exactly right. And so how many people in the room are 26 years old? That's it? I thought all of you were about 26. All right, it was a really good time in my life, which is why I keep framing questions as 26. I miss it. Anyway, so exactly. So I mean, it's a similarly aged woman, it's a similar setting, it's a heated argument, but you step in as a physician and you start to get some more, sort of history. This has happened before. She's looking very pale. She doesn't have any of the, sort of characteristics that the prior case had. So in this scenario, how many would do number 1?
Okay, Dr. Singh, now I really quickly made a test poll, so let's see if we can launch it.
Oh, I love it. Oh, wonderful.
So just letters instead of numbers. But
Love
that's,
it.
I guess.
Love it.
Okay, we have 22, 23, 24 responses right now. Okay. Come on, like we have a few more. There we go. 28. Okay. I think I'm gonna share the results now.
I wish you guys could work in the ED more and discharge these patients instead of them coming in for observation. So that's exactly right. You're super well done. Let's see. So let's close that out. Okay. Yeah, so no further testing. And really, exactly like you highlighted before, this is sort of classic vasovagal syncope. Just so you guys kind of start to get familiar with the terms, vasovagal syncope is essentially neurocardiogenic syncope. It's one and the same thing. And so let's go through exactly what happened, what were the differences between our first two cases, so that when you're listening to these stories at the bedside, you start to put them in buckets. Most seizures do not occur when you're standing upright. Yes, you can seize when you're standing upright, but it's much more common to have someone pass out from vasovagal syncope, orthostasis when they're standing upright. The prodrome, like you noticed, which includes people looking very pale, is very common during vasovagal or cardiogenic syncope. This is a trick that one of the neurologists taught me. I've seen it a couple of times in practice that with seizures, you really bite the sides of your tongue. And with a vasovagal syncope, you can sometimes see sort of tongue tip bites. And so just because you have a tongue bite, it doesn't necessarily make it a seizure. Go one step beyond and kind of get more history, examine the tongue. Eye deviation. So most stories you'll hear, they'll say, oh, they fell backwards, their eyes went up, yikes, they had a seizure, right? Because bystanders are reporting these stories to you. Lateral deviation is quite classic for seizures. Upward deviation is quite classic for vasovagal or cardiogenic syncope, and we're gonna watch a video in a second. Muscle movement and tone. So rhythmic and generalized is pretty classic for a tonic-clonic seizure. More flaccid muscle tone is pretty classic for vasovagal syncope. Has anyone seen someone with a vasovagal syncope? Anyone who's been in an anatomy lab, been doing a blood draw? No?
I've personally gotten it.
Say that again, Richard?
I've personally gotten it. When I get my blood drawn, I immediate syncope. It's like a reaction. So
yeah. I'm hoping more for someone who's witnessed it. And I'm sad that you've experienced it. I'm sure there's nothing pleasant about it.
I've witnessed one before.
I've seen someone.
Yeah.
They hit their elbow in it was in high school. She hit her elbow and then immediately she was like, oh, it's coming, and then fainted.
Oh, it's coming. I love that. So she had a prodrome. She knew it was coming. And do you remember her muscle tone? We're probably not in med school yet, so we weren't really studying muscle tone.
She just was like, just fell.
Just
it was like, yeah, it was like flaccid.
Like a rag doll. So if you've ever seen someone fall from vasovagal syncope, it feels like a rag doll falling to the floor. And they usually have felt it coming on before. They'll try to escape the scenario and kind of like almost fall in the process of trying to leave the, I don't know, like the dissection table or other scenarios. Duration of loss of consciousness is a nice little factor you can look at. For seizures, it's really several minutes, and classically for syncope, it's less than a minute. And post-ictal symptoms shouldn't really exist for vasovagal syncope. They might be, as they wake up, they say, I am feeling nauseated or clammy or tired, and that's okay, but they're not confused, right? So keep some of these things in mind as you are evaluating your patients. If you could help me, Rafa, this is the Lempert video on YouTube.
Which video? Could you just repeat that, sorry?
The Lempert video, it's the one in which they induce vasovagal syncope.
Yeah, we have it.
Okay.
Hypoxia. In clinical practice, physicians witness syncope only on rare occasions, so that many phenomena remain unnoticed. This video demonstrates the clinical features of syncope, which we studied in 56 healthy volunteers. Syncope may be safely and effectively induced by a sequence of hyperventilation while squatting, rapid rising, and a Valsalva maneuver. In order to test the responsiveness, subjects are repeatedly asked to count.
Okay, beautiful. That one was not as interesting as the boxing video, right? Anyway, so, this is from back in the 90s. So this is like 50 medical students in Germany, some neurologists doing this experiment. And I love it. Like, you should watch the whole video. It's like one student after the next, after the next. And what they're doing really is to investigate what are some of the symptoms that you're seeing, right? So when they took 56, I think they were actually able to induce syncope in something like 42, which is a pretty high number by doing those 3 maneuvers they mentioned. And then they said, what was the average duration of syncope? It was about 12 seconds. Myoclonic jerks. Did you see myoclonic jerks on the video? Did you see how the young man was kind of moving his arms? So myoclonic activity was observed in close to 90% of people in whom they induced vasovagal syncope. And most people had their eyes going upwards. And if you finish watching this YouTube video, they'll like sort of also film from the head end, where you'll see eyes deviating upwards. And when they woke up, a lot of these young people, because they're completely healthy otherwise, they actually reported some visual and auditory hallucinations before passing out. So that was also pretty interesting. So I guess my takeaway is, like, watch this video several times so that you understand the differences between syncope and seizure. Okay, we're not bored yet. This is awesome. We're almost at 3:30. Anyone with questions so far? No questions? Bailey, you always have some questions. No questions today? Oh, bummer. Your mind is somewhere else. All right, let's go ahead. So this is why I'm obsessed with ESC, is because they make this beautiful picture, and really the pathophysiological classification centers in the very middle, that little white circle, which you have to have cerebral hypoperfusion like we defined. And this can be happening either due to low peripheral resistance or due to low cardiac output. Are you with me so far? Does that make sense? What is that formula everyone learns? Cardiac output is heart rate times stroke volume, right? Something like that? No, it's not the same. Anyway, so a deficiency in either will lead to syncope. As long as you're maintaining a systolic blood pressure over 90, you're probably not going to pass out. But when you start to take that blood pressure down to 60 and under, most people will pass out. And so 60 at the heart level is about 30 at the brain level. And that's usually sort of what's going on as you're syncopizing. So my neighbor who syncopized a few months ago, I happen to have a blood pressure cuff at home, and her husband was like, well, you have it, so you might as well check it. I was like, fine, I'll check it. It's going to be low. Anyway, so I check her blood pressure. It's like literally 60 over 30. And he's like, well, what does this mean? Is she having a stroke? I was like, no, this just confirms it's probably, syncope from some etiology. We'll get to the bottom of it. But the blood pressure being low is not a giveaway for anything. It's simply the mechanism of syncope itself. And so we know that there are 3 main groups of syncope: reflex syncope that we spoke about, which is vasovagal, neurocardiogenic syncope, all the same sort of verbiage. There's cardiac syncope, and really these are the patients that require a lot of attention and close monitoring. And then there's orthostatic hypotension, this really huge yellow bucket right here. And a majority of what you're going to see during a more prolonged inpatient stay is going to either be orthostasis and no one's checked orthostatics, or it's going to be cardiac and they truly need an admission. Most reflex syncope should be discharged from the emergency room, right? Questions over here? trying to think what I should really tell you guys about this. You know, when you're looking at the cardiac syncope bucket, it's important to know that structural cardiac includes PEs. It's not just the heart itself, but it's the heart-lung, you know, sort of plumbing. So we'll go ahead. I don't think we should. So what is the most important thing you're doing as a physician? I'm going to unmute yourselves. And so far, everything that we've talked about for syncope, you know, what's the most important thing when you're doing in the evaluation? It's an internist's favorite thing to do, right? We're really just storytellers.
The history.
Yeah, history, 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 some more history. Excellent. And then, you know, like I recently had this, I don't know, maybe Wanju, you had this case with me. She was in room 61 on the 10th floor, and the cardiologist was super worried that she's had a cardiac syncope, like a cardiac underlying etiology, because she had fallen so hard that she had fractured her orbital base, right? So do you remember, like, he kept saying to me, he's like, well, this is cardiac because she fell so hard. And I was like, I don't know. I don't know if that's true. I don't know if it's a statement you can make, because most of the data says that severity of injury sustained has nothing to do with the underlying etiology, right? I mean, there are
question. Sorry.
Yeah.
I have a question on that, because I usually hear that if you fall on your face, it's usually cardiac. But I had a patient right now in the ICU. She came for pain. She fell on her face, but she had a completely different situation. And I just never understood why they say that.
No, I think that's exactly what I was saying, Galit, is that that's not true. Okay. So I think we make these statements in medicine based on experience, perhaps, right? Because you'll hear a lot of people saying, well, I had a prodrome, I was about to fall, I stretched my arm out to brace myself as I was falling, breaking my radius in the bargain, right? A lot of people have heard that story, so that you know you're about to fall, you brace your fall, whether it's your face, whether it's sideways, and that if it occurred sort of out of the blue without a prodrome, you didn't have the chance to brace. That's what that theory is based on, right? That you couldn't brace your fall because there was no warning. But a lot of the larger syncope data seems to suggest that that's just not true, that people seem to syncopize with serious injuries regardless of the etiology, right? And so let's go over this really quickly. So I know I'm being repetitive, but when you're getting your history, you know, go into the details, ask them, you know, what time of the day was it that this happened? Had you just woken up? Were you eating? Were you going to the bathroom? Was life going as normal? Had life changed recently? Any recent stressors? Any recent, you know, pain? A lot of people will tell you, I was peeing right before I passed out. I had a large bowel movement right before I passed out. I had this massive steak before I passed out. So get that story. Were you standing when it happened? Were you sitting when it happened? Were you changing positions? Did it happen during exercise? This is really a huge red flag. When someone says they passed out when they were exerting themselves, I become very quickly suspicious that there's an underlying cardiac reason that they syncopize. So exercise is an important question. Did it happen with quick head turning? So a lot of patients who are trying to actually describe vertiginous symptoms will try to tell you it's syncope. So tease that out. Was there a prodrome like we've seen in our prior case, right? So aura, nausea, diaphoresis, palpitations. Palpitations, again, a red flag. When people say palpitations to me, I kind of say, yep, you probably need to come in. We need to investigate you a little further. And then recovery. Did they have a rapid recovery or prolonged symptoms? And when you're doing that physical exam, please check their orthostatic vital signs. Do it yourself, please, please. I cannot emphasize this enough. This is why in every question stem, I keep putting orthostatics normal. And my teams will do this with me on rounds, right? We do it together on rounds. You wait 3 minutes before you recycle. ACC will say, do it lying down, do it sitting up, and do it standing up. Really, no one's got time for that. Ain't nobody got time for that, right? So just do it lying down and do it standing up, right? Look for tongue findings, look for focal neurological deficits. Every syncope patient must have a full neuro exam. Do a cardiac exam, right? I mean, your generation is probably going to put a POCUS on their chest. That's fine, but do it, right? Find out if they have some kind of avalvular abnormality. Change positions a couple of times and see if your murmur is changing. No one does PMI. Even I don't do PMI unless my patient's really skinny and I can like actually feel it. And then injury pattern, like we were saying, right? Did they brace their fall? And I think peripheral edema is really important because in the world of hospital medicine, we do obsess over perhaps the correlation between PEs and syncope. And so if there is asymmetry, you start to get a little concerned. And again, just perseverating on my same old thing. How do you measure orthostatics? Measure it lying down, stand them up, wait 3 minutes before you cycle. And if you have a fall of 20 in your systolic blood pressure or 10 in your diastolic, that's a positive orthostatic. One thing I didn't include, and which is really important, and I say this all the time to my teams, between this history and physical, it should always be followed by a medication list. You really want a robust list of medications because multiple medications cause orthostasis. And there's a couple of scores that have been developed over the years. One is this EG SYS score. And the reason they've developed these scores really is to do triaging at the ED level. Here, let's skip a slide ahead. Is to find out, is this likely to be a cardiac syncope or is it more likely to be one of the others? And some of these things are fairly straightforward, right? So abnormal EKG straight away gets 3 points. Palpitations, like I said, straight away gets 3 points. Syncope during effort, major red flag. Syncope in supine position is concerning, right? So, and you actually get negative points when it starts to sound like a vasovagal syncope. So this is a helpful sort of scoring system to have in the back of your head as you're admitting your patients. And there's a similar one called the San Francisco syncope rule that you could choose to use instead. And this is a little bit more for patients, you know, with sort of complex medical histories, heart failure, anemia, et cetera, to give you a sense of how are they going to do when, like a lot of syncope patients, when they're admitted in the hospital, you try really hard to get to the bottom of it, but you didn't successfully find orthostasis and you didn't convince yourself that it was vasovagal and their cardiac workup was negative, right? That happens a lot. You're discharging and saying, well, hopefully they'll get a Holter or a loop in the future for like arrhythmia monitoring, echo looked okay-ish. And this is, for me, like I try to do this little scoring for myself to say, are they going to be okay? Should I really push hard for them to get this loop before they leave, right? Like that patient 1 June who'd broken her orbit. I was like, does she really need this loop in patient? When I was doing her San Francisco syncope rule in my head, I was like, nope, she does not, right? She did not. Anyway, so let's do case 3. Jonathan, do you want to read this case for us?
Sure. 26-year-old female, no significant past medical history. Syncopes in the setting of a daily run, prodrome, lightheaded, palpitations briefly. Witnesses, blue lips, arms twitching, eyes rolled back. On waking, felt well, ready to run again. Further history never happened before. Workup, not orthostatic. Normal exam in lab and labs, and abnormal EKG.
Okay. Who's going into cardiology?
Looks like there's.
I know some of you are.
I mean, I can pick on 1 June, but like I'm sure others in this room are for sure. Okay, 1 June, you want to give it a go?
Sure. So looks like we have what could possibly looks like we have a normal sinus rhythm rate of about close to normal rate of 60. I am seeing as far as axis goes, possibly a right axis deviation. I see T-wave invergence in the anterolateral leads in V1, V2, V3, V4, V5. I think there's also QRS widening.
Excellent. Yeah. So what is the criteria for right axis deviation?
So the way I do it is usually if it's if the vector is basically negative in 1 and positive in AVF, usually that will indicate a right axis deviation.
Does anyone do it a different way? Yeah, I do it similarly, right? So, and what's an epsilon a wave?
I think epsilon waves usually come up when patient is hypothermic.
So do you see after this QRS in V1 and 2, you see this funny little notch right after?
Oh yeah.
Yeah. Apparently that's called an epsilon or epsilon wave. And I only know this because there's a case on my service and I had no idea before this that this kind of wave exists. But essentially, so now you know what's going on. What would you guys do?
Echo.
Sounds like a good call. We can skip the poll. Yeah. This is an entity worth knowing again, and I had not seen it, but arrhythmogenic right ventricular cardiomyopathy is sort of well known to cause ventricular tachycardias. And so when a person like this, who's a very young woman who's got great exercise tolerance, suddenly passes out when they were exercising, it's hugely concerning when they walk in with an EKG that doesn't look normal. Right? A 26-year-old should have completely normal EKG. We know she has a right bundle. We know she's got inverted T waves. That's this creepy little epsilon wave, which apparently indicates, and I only learned this recently, that you have right ventricular cardiomyopathy and possibly a right ventricle, which is much more likely to cause ventricular tachycardias. Okay. Bailey, do you want to read case number 4?
Sure. A 46-year-old male, syncope with rushing upstairs in the morning. So history of hypertension, he's on lisinopril 10 milligrams daily. Before the event, he had brief lightheadedness, no palpitations, chest pain. No one witnessed it. When he woke up, he was confused for about 5 minutes. There was no incontinence. He didn't have breakfast that morning, blood pressure, normotensive, his heart rate, normal. He was mildly orthostatic. His EKG was normal and there was normal exam and his labs are within normal limits as well.
This is a pretty typical case that comes in, right? What would you do? We can do a poll here, Rafa, if you have it. And if it helps anyone, let me just go back a slide to show you the stem again. You have a 46-year-old rushing up the stairs.
Okay, we have about 50% participation right now. So remember, it's anonymous. Just
can you go back to the answers?
Yes.
Okay, we have a 76 participation right now. I'm gonna, I guess, share the results now.
Yeah, I mean, I'll admit it was also my impulse. It's like, looks a little dry, a little orthostatic, a little uremic, hydrated, and probably just passed out from orthostasis. Lisinopril doesn't help. The thing to remember in a case like this, right? Like, you're collecting so many pieces of information, is anytime it's happening when you're exercising is not a good sign. Right. I mean, if he had just been standing at his kitchen sink and doing the dishes, I would agree that I would choose the one. But this guy's rushing up a flight of stairs. I really worry that something bad could be going on. And I might be wrong, but I want you to start taking exertional syncope pretty seriously. Right. Okay. I'm making this up. This is not a real case, but this is what could happen, right? When you send him home after hydration. They suddenly get on the treadmill and they have this idiopathic outflow tract VT. This will not happen frequently, but it'll happen once in a while. So what are the indications for cardiac testing? An echocardiogram should be part of the extended workup when a cardiac etiology is suspected, right? There's a lot you can do before you need to get to an echocardiogram. Every syncope is not cardiac. Most syncopes are orthostatic or vasovagal. And what about exercise stress testing? It's most valuable if you've syncopized during or immediately after exertion, right? So think about that bucket of patients. And in general, syncope is not, you don't always have a conclusive answer at the end of a hospitalization or at the end of an evaluation. A third of these end up being vasovagal or neurocardiogenic. A fourth of them end up being orthostatic. And for a lot of the other cardiac etiologies, you don't often have an answer right away. It ends up being an outpatient workup. I always say this to my teams, when you put someone on telemetry, you should know what you're looking for. The yield of telemetry on an inpatient admission for bradycardia is pretty high. You will uncover 40 to 50% of bradycardic events. But for tachyarrhythmias is really poor. It's less than 20%. Some literature says less than 15%. So if you're really suspecting a tachyarrhythmia as the underlying etiology of your syncope, that patient needs outpatient monitoring. Some of the other things, that at least in this study, and this is almost 20 years old, that they uncovered when they started digging harder and doing more investigations is 1% of their patients ended up having aortic stenosis, another percent had PEs, and some actually ended up having strokes and seizures. And I would caution you again that you need to weed out the real etiology. And this is actually from the American Cardiology guidelines, which is just to say, use your tests wisely, and everyone doesn't need every test. When your evaluation is fairly straightforward for vasovagal syncope, you don't need any more testing. If you're not sure what's going on, do some initial blood tests to figure out what's going on. If you start to notice sort of vasovagal syncope as your leading differential, but you're not sure, or it's a very high risk patient due to occupation, you can go ahead and do other testing. And then really only with cardiovascular abnormalities, when your exam suggests it, your story and your EKG suggests it, you do the rest of the more nuanced testing. We're at 3:50. I think we need to start wrapping up. I don't think we have that much time. So I'll read this one out. So it's a 40-year-old orthopedic surgeon. So every time she operates and stands in the OR for a long time, she seems to have these episodes of syncope. She seems to go to the ER because she's right there in the hospital, and every time they tell her she's fine. You do an exam, the blood pressure is okay. There's not true orthostasis. And the labs are mostly fine. You also make sure, because you're very astute, that she's not pregnant. And so what would you do next? Would you get a brain MRI, echocardiography? Would you do 24-hour ambulatory electrocardiography, which is just a Holter? Would you do tilt table testing or no further testing?
You want me to relaunch the poll or no?
Not really. Just okay. Raj, do you want to unmute and give us a opinion?
I mean, when I was looking at the stem, if it's only happening when she's doing surgeries, is that the case?
Mm-hmm.
Approximately 2 hours, I would say no further testing. It sounds like she just needs to sit and have a sip of water, probably.
Yeah, wear some compression stockings or something, right?
Yeah.
That seemed to be split between 4 and 5.
Okay, yeah, excellent. So you guys hit the nail on the head. I don't think either answer is incorrect. You could do 4 or you could do 5. And the problem, again, the boards test this, which is why I threw it in. The answer goes back to what's the best option for her. And she's a surgeon, and she was going to continue to operate for several more years. She needs a definitive diagnosis, right? And that's really the reason behind tilt table testing. Tilt table testing is most useful when your suspicion is fairly high that it is from vasovagal or orthostatic causes. It's not useful in other settings. And again, this is from the ESC, so you can look at it later. Here we'll go through case number 6. Here you have an 83-year-old. They have CKD stage 3. They used to have cancer, and they're going for a walk, a daily walk, which they do every day, and they syncopize. There was no prodrome. Nobody saw him syncopize. When he wakes up, he's a little short of breath. He's a little nauseated, says he has some chest pain. This has never happened before, but he was on a road trip 2 weeks ago. When you evaluate your patient, the orthostatic systolic blood pressure drops from 100 down to 80, becomes a little tachycardic. You notice a little bit of a JVD. You listen to their heart, there's a systolic murmur. You see a +1 edema only on the left leg. You're so good. At this point, you're like looking for bruit. The creatinine is slightly up, but close to the baseline. The EKG doesn't look okay. This is the EKG. Raphael, do you want to give it a go?
Yes, sorry.
No, no, okay.
So it seems regular for me.
Mm-hmm.
6. Heart rate around 190s. I see P waves before each QRS. V1 lead one is QRS is negative, AVF is positive, so right, the axis is deviated to the right side.
Mm-hmm.
QRS is not prolonged, PR not prolonged as well. Yeah, just for me, it's just sinus tachycardia.
Yeah, wonderful. So they're tachycardic, which you identified. There's a right axis deviation, right? And will someone repeat to me what a right axis deviation is? Arpan, do you want to just repeat exactly what Rafa and Wanjun said?
Yeah, sure. So to look for right axis, we generally look at like lead 1 and lead 2. So you can just see the vectors. If they are both up, it's normal axis. And like if it's negative in 1, positive in 2, it can be right. And yeah.
So you got a negative in 1, and then you got an upright in 2 and an upright in AVF, right? So that's the right axis.
Yeah.
Okay, excellent. Do you guys see inverted T waves anywhere?
Yes, there is inverted T waves in B1, B2, B3.
Excellent. And lead 3, right?
Yes.
Excellent. Okay, beautiful. So what would you do next? Nadeem, if you want to just unmute yourself and pitch in.
Wait, did we say there was a BRE or was there no BRE on exam?
No BRE.
There's no BRE. I don't know, like the patient is tachycardic, had a recent like road trip. I was thinking something like PE to rule out. So I don't know if we would do option 3 to.
Brilliant. So you do that and you get a trope of 0.18, you get a D-dimer 2000, and you get a BNP of 655. Nadeem, what's the next step?
CT, like angio chest.
No, it looks like crap. There's filling defects everywhere. Okay. So what is the role of D-dimer testing? And this was very controversial. This is from back in 2016, where they took about 500 odd patients, between 500 and 600, and said, we're going to put all these syncope patients through a CT. And of that study population, 1 in 6 ended up having a PE, right? So everyone was like, yikes, are we missing a lot of PEs? The important thing though in the study, like when you really start weeding through it, is that only 22% of the patients that were initially screened ended up being enrolled. So the suspicion is, and much larger, we're going to skip through this. much larger meta-analyses have actually shown that you don't need to evaluate for PE in all syncope patients, but you do obviously need to evaluate for syncope where there is the suggestion that there is one, such as our patient, right? So not every syncope patient needs a PE eval, but you want to think about it as a potential etiology, right? This study will come up over and over, which is why I've put it in. I'll send you guys the slides. In the interest of time, case 7 is a 69-year-old with asymptomatic paroxysmal AFib and hypertension. They're on Coumadin, becomes unresponsive while watching TV, was a little lightheaded before, eyes rolled back according to the witness. And then he woke up and he felt totally fine. This had also happened 2 months ago. They're not orthostatic. The exam is normal. Labs are normal. The EKG shows sinus bradycardia, but otherwise okay. What kind of cardiac monitor is the most appropriate? Joe, do you want to take this one?
Yeah, sure. In my head, I was about to say probably needs a cardiac monitor, and then you asked all the different types. So that's great. I'm not sure, to be honest. I guess you go short for the beginning and see what happens. So like maybe the 48-hour one.
Yeah, I mean, in practice, you're probably going to end up doing whatever is most easily available and hope that you capture an event. But the idea is to do something that's frequent enough, that's long enough that it captures whatever frequency the patient is experiencing, right? So there's no wrong answer. You could do any of them, but there's one best answer, right? And then this is, again, just for you guys to quickly look at. EKGs are wonderful, but remember that they are simply a screening test. The yield is quite low. Like, you literally have to be going through your arrhythmogenic event in the moment for it to be captured. Holters are great, but will only capture something, like I said, less than 20% of tachyarrhythmic events. Event or loop recorders, so this is up to 30 days, are quite useful. Implantable loop recorders are sort of becoming almost standard now, because we know that our patients are syncopizing infrequently. They need something longer term. And then you will notice some of your patients for whom it starts to become more challenging, they will go through EP studies. All right, we're going to skip all that. What I wanted you guys to see, this is from the European guidelines and this is from the ACC guidelines, is that even for reflex syncope, there are treatment options. And this is important to remember. I've seen too many patients in whom, they'll keep passing out and all people have to say to them is, well, good luck, like, it's not dangerous. The options are many, and it really depends on where they're at in terms of how many times they've syncopized, how frequently they syncopize, what kind of a job they do. But I've seen people treated anywhere from, just simply with midodrine and fludrocord, and you'll see this pretty frequently, and they'll say, I'm on it because I was passing out and my blood pressure was low, and that it was not acceptable for me to pass out so many times. And you'll see it all the way to sort of cardiac pacing and getting pacemakers for this. So just because it's reflex syncope doesn't mean it doesn't need to be treated. Obviously, the first measure is education and lifestyle, but there are other options. And here's a quick summary. So history. Always get orthostatics and an EKG. Do a targeted workup, right? You've gotten a good history. Now really go after what you think is leading your differential. When you're deciding at discharge what kind of a cardiac monitor your patient needs, obviously the cardiologist weighs in, but always advocate for your patients. If you feel like their events are infrequent, they need longer term monitoring. These patients don't need brain imaging. Do a neuro exam. If you're convinced they need brain imaging, then send them for brain imaging. They don't all, you don't need to pan scan their heads. And that is it.